Dislocating a hip is not pretty, let me tell you. Here are 3 very important moves that you must not do if you've had a total hip replacement. Although you've now got a new hip, a new ball, and a new socket, the entire purpose of trying to avoid these 3 moves is because that hip can dislocate. Hello everyone, my name is Joy Agude. I'm a chartered physiotherapist and the founder of the London Physio. We are a private bespoke physiotherapy service and we deliver our services predominantly virtually, so you can tap into this from anywhere in the country, but we can sometimes provide home visits and clinic sessions as well. Now today's video is all about the 3 super important moves that you must avoid if you're recovering from a total hip replacement. Now, before I go into it, I would like to ask you to subscribe and please click the like button. Give this video a thumbs up. It helps people like yourself who need to get some value from videos like this. It helps the video find them and them find us. So please don't forget to subscribe and click the like button. Here are a few things that you can expect to learn from this video. So number 1 is the anatomy of the hip. If you have gone as far as having hip surgery, you ought to know the anatomy of the hip, how it works, why certain movements might not be very good for the hip. So I'm going to go into that and just things like the kinds of positions that the hips could possibly be in. And then I'm going to tell you a little bit about hip surgery. Just briefly, I'm not a surgeon. Obviously, I've treated a lot of hip replacements over my 15 years of being a physiotherapist. I'll just give you a quick overview of what actually happens during hip surgery and what to expect. I'll also be letting you know about the 3 moves that you must never do, what they actually are, and how they show up in everyday tasks in a way that most people don't even realize they're doing them, and that's what leads to the problem that we're actually trying to avoid. And then most importantly, at the end, I'll tell you what to do instead. So it's all well and good saying, don't do this, but then it's like, okay, what should I do? So I'm going to help you with that process as well. Please remember, this is not to replace your one-to-one advice. If you were my one-to-one client, obviously, you will have a bespoke exercise program and everything else, but please do not use this video to replace actual real life information that's been given to you by people that know your medical history. Now, without further ado, let's get into it. So a little bit about the hip. The hip is a ball and socket joint. The socket accommodates this ball and it's what keeps it from dislocating. But because it's a ball and socket joint, there is a lot of movement in the hip, more than you would see in a joint like, say, for example, the knee. So with the knee, you can only bend and straighten, right? Flexion to bend and extend to straighten. Whereas with the hip, you can do the flexion and extension, meaning you can lift the knee up to flexion, or you can bend the body forwards into flexion, or you can do other moves like abduction, abduction, taking the leg away from the body and bringing the leg towards the midline is adduction. So you're adding adduction and abduction. And then even more is the amount of rotation there is in the hip. So you have something called internal rotation and external rotation. So imagine this is your ball and socket. Internal rotation would be you turning the ball inside the socket. And by the way, the socket sits on the end of your pelvis, right? The head is coming from the femur and you are internally rotating the femur, as in the thigh bone or your leg, if you like. You're turning it into the socket, and then external rotation would be that you're turning out of the socket. Just because of the ball and socket nature of the hip, sometimes we do a combination of these movements and we don't even realize it. So something like sitting and crossing your legs, for example, you know, the way a man maybe might sit, and I sit like that sometimes. You're doing a combination of movements. You're doing the flexion, you're doing the abduction, and then you're doing the external rotation. So your hip is a very dynamic joint, and it's held in place not only by the deepening of the socket and the ball in the socket, it's also reinforced by some soft tissue. So ligaments, for example, around the hip, but also tendons which attach muscles to bones. The muscles are obviously very strong around the hip, or they can be if you train them. So the hip stays in place despite this huge amount of movement that can happen around the hip. So when it comes to hip replacement surgery, I'm going to be very careful here because number one, I'm not a surgeon. And two, there are lots of new research and even materials that they use for the surgery. Lots of things change how they do the surgeries, the procedures, and all these sort of things. I'm not a surgeon. That's your surgeon's job. They will tell you what procedures they're doing. They will tell you whether it's cemented, uncemented. They'll tell you the types of materials they're going to be using to replace the ball in the socket. But for the most part, when it comes to a total hip replacement, the reason why it's called a total hip replacement is because both the head and the cup are replaced. So they're obviously going to take your head away and they'll take your cup away, and then they will replace that with whatever materials they've decided to do that with. Could be metal, could be, I don't know, ask your surgeon, right? So, but the idea is that they will be taking those two bits, the head and the socket, or the ball and the socket, and they're going to be putting a new one in. So by the time you've had the surgery, you're going to have a foreign body as your new head and a foreign body as your new cup. But in order to get to the cup, the ball and the socket, they obviously need to cut through soft tissue, skin, fascia, muscles, tendons, ligaments, all of it, fat. They need to be making, certain incisions. And so I tell you this to let you know that post-surgery, there's a lot of healing that takes place. The reinforcement of the hip is not as strong because they have now cut through some of these muscles. And the reason why that's really important to know is because you have to avoid these three things in order to, drum roll, stop you from dislocating your hip, because your hip is at huge risk of being dislocated because it no longer has that enforcement. Although you've now got a new hip, a new ball, and a new socket, you still don't have that reinforcement. So the entire purpose of trying to avoid these three moves is because that hip can dislocate. And dislocating a hip is not pretty. Let me tell you, I've had patients who have gone through total hip replacement surgeries. One of them dislocated within 2 weeks of having the surgery. He just didn't keep to the hip precautions. And he would confess that himself. He's like, oh, I've had so many injuries in my life. I can just do this and I can do that and he had to go back into surgery, and it's awful. The patients hate it. The biggest thing that I find with patients who have dislocated is that they really lose their confidence. I have another patient who dislocated months after her surgery. Unfortunately, she had a surgery with the NHS, which is not unfortunate. What was unfortunate was that they didn't refer her to physio after that. So although she's a private patient now and she's seeing me privately, they didn't refer her to physiotherapy, and so she didn't actually get the strength reinforced in the hip. But further down the line, much later down the line, so about 5 or 6 months in post-surgery, she was just bending to pick her phone up and dislocated. So I'm not saying this to scare you, but I'm letting you know that this is possible. We see it in patients all the time, and it's my job as a physio to help you avoid dislocating as much as possible. So without further ado, let's go into these 3 moves that you mustn't do in order to avoid dislocation, and more importantly, what you should be doing instead. Move number 1 is no hip flexion above 90 degrees. So if I was looking at you from the side, a side profile, you definitely don't want the knee higher than your hip. You want the hip always higher than your knee. That is how you know that even when you're sitting, you're not sitting with more than 90 degrees hip flexion. Hip flexion is actually one of the exercises we give post-surgery, but just make sure that even when you are standing, you're not bringing the knee all the way up, because if you're bringing the knee all the way up doing the marching on the spot exercise, you're technically going against your hip precautions. Same thing when you're laying down. That knee needs to sit directly above the hip if you were looking at yourself from the side. And in fact, what I would say is let the knee sit lower than the hip all the time. Another common way that people do the hip flexion is when they sit and then they try and bend down to pick something up. It's a no-no. After your hip surgery, get something like a grabber, which is this super long thing that you can just use to grab things, right? If you've dropped a pen, you have no business picking it up. Get somebody else to do it for you, or get a grabber and then use that to pick the pen up from the floor. It's the same as if you were standing, okay? So I do not want you bending forwards, because remember, ball and socket, the socket is attached to the pelvis. It's still 50% of the hip joint. This is what you should do instead. Get a grabber, that's number one. Number two, say for example you live alone and you're like, oh my God, I just dropped my phone, I need my phone. What you definitely don't want to do is just bend forwards and pick it up, right? So if your balance is great, okay, I would say definitely hold on to something. And also this depends on how far into surgery you are, but definitely hold on to something. So extend the leg so you're in neutral, and then make sure that you bend with your body, but your body and your leg are in line with each other. And then that way you do not run the risk of bending past 90 degrees. Of course, your other leg, your other hip is going to be bending past 90 degrees, but not your operated hip. That's the plan Z. The last example I'm going to use for addressing hip flexion is getting into bed. So people sit in the bed, lift the leg up, and then just bring themselves into bed. Do not do that. Every time you get into bed, you're going to be going against, kind of these hip precautions. So as a physio, there are lots of different ways we kind of help with that. Bring the bed up to a certain height so it's really high. Even things like sitting on the toilet, just get yourself a nice toilet surround so that the toilet's sort of higher, or like a combi toilet frame, or even just a toilet frame on its own. You can normally get that nowadays. There are things like leg lifters you can use. I can make a whole video of that, okay? But number one is do not go past 90 degrees with hip flexion. Move number two is do not twist the hip. Now remember, we talked about internal and external rotation, where the ball turns into the socket and out of the socket. That's exactly the move that we're talking about here. So a lot of people do that when they're sitting and then they try to reach for something. So bear in mind the hips are staying where they are, but then you're sitting and you're trying to reach behind you, you're turning your body. Technically, you are internally rotating on the side you're turning towards and externally rotating on the side you're turning away from. In the same light, when you are standing, and at this point, maybe shortly after your surgery as well, you might either have a frame or you might have elbow crutches, depending on how far down the line you are. It's things like standing up and then trying to reach behind you, talk to someone behind you. Someone calls your name, you're like, oh, hey, what's up? And then you turn around, gone, dislocated, on the floor. Do not do it, okay? Don't do it. Instead, what you can do is take little steps round. So whatever you're using to walk, if it's a walker, especially if it's a walker, just make sure that for every step that the walker takes, your feet are facing in the same direction as the front of the walker. So instead of going from 0 to 90, you might take like 2 steps or 3 steps, depending on how little your legs are, okay? Or how much pain you're in, or even how much further you are post-surgery, okay? But don't do the twist. Don't twist round. That will almost certainly cause you to dislocate. So please don't do that. Move number 3 is do not cross your legs. Specifically, do not cross your legs past midline. So I know that there are different ways of people crossing their legs. So for example, men will sit in sort of the figure 4 position. I love sitting in the figure 4 position. It's external rotation, abduction, a bit of flexion. It's not ideal just because you probably would be going past that 90-degree hip bend anyway. And why are you sitting in that position after surgery? Like, do you have a death wish? Like, why? The main thing about crossing the legs is going past midline. So the middle of my body is my midline, right? Taking that leg, the leg that has been operated on, and crossing it across the body, so towards the other side. How most women might sit, for example, sitting and just putting one knee over the other knee. And a lot of men sit like that. I don't know why I keep referring to gender like it's even a thing here. It really isn't. Just don't put your leg one knee over the other. Also, a lot of people do this bad habit when they're standing, where you're just like standing, having a chit chat, and then you just put one leg in front of the other and you stand on one. Don't do it, okay? And mind you, some people would say things like, oh, but I was only crossing the other leg. Yeah, but as long as the unoperated leg is crossing the midline, so is your operated leg, okay? That's just how your body works. So please do not do that. And in terms of what you should do instead, do nothing. You do not have a death wish. You want to get better, remember? Do nothing. Just stand normally. Stand with both legs down, or sit with both legs down. Just keep your midline to itself. Don't add anything to the midline. No adduction, okay? So don't add anything to the midline. Okay, so just to summarize, move number 1 is do not bend the hip past 90 degrees. Move number 2 is do not twist. And move number 3 is do not cross your legs past the midline. Now, it's important for me to let you know that post-hip surgery, as long as you've got a good physio, I've had so many successful total hip replacement, rehab with hundreds of people over my 15 years of practice, right? And most of these people can actually do these things, but they're not allowed to. That's the thing. So you might think that, I'd be in a lot of pain. Why would I not? If you've got a really good physio, your physio will help you through the process of rehab, through every stage of rehab. I mean, sometimes I see my patients multiple times a week. Sometimes I see them once a week. And then sometimes that might get more spaced out. The better they get, most of the time they can actually do these moves. Most of the time I'm begging them not to. And as a good physio, I'm constantly reminding them that they should not be doing these moves. So if you're someone who forgets, have more physio sessions. So your physio will always remind you. Or just put things on your walls, like when you go to the toilet, put notes there that you can't miss. When you sit in your living room, just have visual cues around. As long as your surgeon has not said that you are off the hip precautions, make sure that you continue to abide by those rules until your surgeon says so. And usually what they will do is they'll get you in for a few appointments after you've had an extensive amount of physio, and then they will ask for your physio report and everything else. Your physio will give their opinion, and the surgeon will have a look at your x-rays, probably re-x-ray you, or look at your movements, do a clinical assessment, and then say, yeah, you're good to go. If you haven't had a hip replacement yet and you're looking to have one, this would actually be really good for you to start getting used to pre-hip surgery so that by the time you have your total hip replacement, you're already used to it. Thank you for watching this video till the very end. If you've got this far, then please remember to subscribe and like. Now, if you don't have anyone looking after you, or you want a second opinion, or you just want to switch, come over to the londonphysio.co.uk. I would be more than happy to look after you. So just head on over to allthews.thelondonphysio.co.uk and click book now. If there are any other videos that you want me to make, be sure to leave some comments down below. Meanwhile, if you've enjoyed this video, you might also like this other video, so make sure you click here and watch that. Until next time, bye.